Okay, I think we need to begin so we get a chance to do justice to the work that we still want to finish that's ahead of us. There's a little extra surprise for us this morning. We talk about issues that challenge us, and they tend to be of two kinds in terms of getting things done. They're regulatory aspects, and then they're funding issues. And of course, there are others in trying to access the care we need. Had a wonderful conversation about 3 weeks ago with Dr. Agnes Klein, who first joined us in Winnipeg a year ago at a conference we had there, and is committed to working with us cooperatively and collaboratively. Dr. Agnes Klein is director of the Radiopharmaceuticals Approvals Branch for Health Canada. And she was unable to make it today, but she has sent one of her esteemed colleagues, Dr. Viner, who just came in at the back here, and he's representing Health Canada and will describe for us basically a little bit of his role and what that looks like. So we have a bit of an appreciation for that as we segue from the first series of presentations this morning and move into the very practical action steps that we're going to put everybody to work on in the last session. Dr. Viner.
I don't think I'm doing that. Somebody's doing that for me. Well, I want to thank and congratulate CNETs on this symposium. It's quite amazing to come to a meeting like this and see the interaction of patients and scientists and medical specialists together. It's very unusual, and it looks tremendously effective. And I think you could export your model to many other diseases. Maybe it's a business model for funding. I don't know. And I also want to thank Jim and Maureen for inviting me here. I don't see Maureen wherever she is. Now, I don't have any pictures of Tunney's Pasture. I don't know if any of you have been to Tunney's Pasture, but I think we rival Dr. Buscombe's buildings for ugliness. Maybe we surpass it in the ugly building field. He's not listening, so. So I'm going to add to your PowerPoint overload. I got 20 slides, but I promise I won't read them all. And I'm going to talk about some of our organizational structures and context and responsibilities that the feds do, and nuts and bolts of regulations, very, very limited overview of that, and some of the opportunities that may be available through our structure. So Health Canada is a pretty big place. There's 12,000 employees, so people will come up to me and say, "Do you know so-and-so?" I think good luck. Although I must say, the other day I was complaining about my Rogers bill, and the young woman at the Rogers billing said to me, "Do you know so-and-so?" And it was our head of policy in our organization. I was quite amazed that I actually did know them. This slide sort of orients you to the high-level organization within Health Canada, with the red being the branch that where I reside. And it shows you where your targets are, maybe for advocacy. And the one thing I'd like to point out to you that I think is relevant is that when you're advocating, there's probably two routes to go. You can go directly to the source, like perhaps my boss or me, and say, why don't we have clinical trials, or why is that clinical trial being blocked, or you can go the political route. But in fact, when you do the political route and you write a letter to the minister, the first thing that happens is it comes back to us anyway. So I think you have to realize that the message should be the same, and I see this organization as doing that very logically and rationally, and there's no issues there. But what happens is the minister will say, through ministerial correspondence, tell me what's going on so I can answer this question. So it just comes back. It's a different route for the same thing, in essence. So when you filter down to the branch where I work, there's two areas within that, both highlighted in red, where the clinical trials and the drugs are approved that you're interested in, and that's in the Biologic and Genetic Therapies Directorate for the more complex molecules, and for the synthetic molecules, it's in the Therapeutic Products Directorate. And curiously, we have a special access program for trying to access products. That resides in the Therapeutic Products Directorate, and I'm responsible for clinical trials in the Biologic and Genetic Therapies Directorate. So when somebody says to me, why is your organization doing this? And I think, well, I can sort of answer that, but I can only answer for my specific silo, and that's one of the problems of big organizations. So when it comes to responsibilities, the feds, basically their mantra is safety, efficacy, and quality. So that's basically our role. There's a lot of other things that we do in all different kinds of areas that other people are responsible for, but certainly that's our main focus. And when it comes to the provincial side of things, they're the ones that do the managing and delivering of healthcare services. So if you're wondering why there seems to be fragmented across the provinces, that's the fundamental reason. We didn't create this system, it evolved to what it is. So when you look at all the federal legislation guidance and you're wondering why we're not doing everything, I think it's important to note some of the things that haven't been listed when I mentioned the regulations. You don't see anything there about funding. So when it comes to regulating, it's not funding. Funding is done by CIHR or by private sources, companies. So also, we don't do public health. That's done by the Public Health Agency of Canada, where all your numbers for your disease come from. Who knows about that or doesn't know about it is a better way of putting it for things like CNET or NETs, because we talk about the incidence, we think it's going up, we don't know. That's all done by public health. And of course, the healthcare delivery is done by the provinces. And there's in fact an inherent conflict for the regulator to participate fully in drug development. It's very hard to critique and come up with the ideas at the same time, and to want to do something and say you can't do it for this reason. And so there is an inherent conflict. So as individuals, we can give advice and we can help, but as an organization, officially, we don't endorse research. And when it comes to the definition of a drug, I've had long talks with Sandy McEwen, who has had to leave. Things like PERS get caught as drugs when maybe it would be better that they weren't, but they fall into the definition. And not only do they fall into the definition, they have classically fallen into the definition of a new drug that requires, by regulations, clinical trials. And so when we talk about new drugs, it has its own set of rules. And the only reason I mention that is because there is a class of drugs called old drugs that don't need rules. And so perhaps reclassifying some drugs maybe earlier in the process, when it makes sense, to avoid the requirement for clinical trials, is an opportunity that can be exploited. So I show this slide it's kind of outdated now because we're moving to electronic submissions. But I have to tell you, when we moved to electronic submissions, the very first data package that came in crashed our system because the single data package was greater than the capacity of our electronic submission. So we're very spoiled with the amount of data we get to review, or tortured by the amount of data we get to review, depending on how you look at it. And that's not a luxury that I think you have when you're generating data from the kinds of products that are required to treat neuroendocrine tumors. There's no big corporate sponsor, obviously. So we've gone through how we regulate, and I don't really need to go into this, and I've discussed the efficacy, safety, and quality. I do want to touch on quality, though, because it's generally, and I hope the physicians in this room are not insulted, and some of them are and do have expertise on quality, but in fact, it's for the most part outside of the physician's expertise. And there's many historical and current examples of safety issues residing in the production of products that really do require regulations, because when there are corporate entities producing these things and there's lots of dollars to be made, there's corners that can be cut. And everyone likes to give the regulator a hard time, and there are examples, of course, when we're less than perfect and we get in the way where maybe we shouldn't, and that happens, but there are many other examples that receive a lot less publicity, where there are safety issues that have come to light, where production has been halted, not necessarily voluntarily until encouraged by the regulator. And so that level of scrutiny is not something you necessarily want to give up, even though it may seem to expedite things at times. When we talk about managing risk, it was interesting. I heard a term in the lectures today that I hadn't heard before, theranostics. And it's an interesting term, and it's a blended term of therapeutic and diagnostics, and I think it's very useful conceptually because of the continuum, but at the same time, it also blends together the risk continuum as presenting it as not necessarily a continuum. So when it comes to the diagnostics, the doses are different, the technology is different, and the risks are different. And when it comes to the therapeutics, as Dr. Krenig has suggested, there's still a lot to learn. There's cases of leukemia being caused by misadventures with dose, and there's reasons for clinical trials and for scrutiny and lots of opportunity for learning, where the regulator has a role to play. And this is where another opportunity that I'll summarize at the end is, when it comes to these areas, the regulator has a very hard time keeping up with the level of expertise out in the community. When we look at CNETs, it's sort of like the physician community in general knows next to nothing about it, and when we look at the proportion of our applications that would come into Health Canada or into my shop, which maybe does 500 clinical trial applications a year, I mean, how many of them will have to do with neuroendocrine tumors? It's a pretty small fragment. And so a route for advocacy and a route for helping us see our way forward is through scientific advisory committees. And this is another area of advocacy where, you pick the right people to advocate on your behalf that have the expertise, that come to us and help direct us and mitigate risk. There are a couple of ways to speed up the availability of products, but of course they're mostly based in the drug model. The one that I think is most promising for you in the room as patients and for the physicians that want to bring the treatments to you is a kind of blending of what we call our special access program with our clinical trial program. And Sandy McEwen alluded to that, Dr. McEwen alluded to that as the regulatory hurdles that he thinks he has overcome, and hopefully he's correct, and certainly we'll do everything we can to assist him in that, to bring lutetium as soon as possible to his clinic. With biologics, which is my area, I'm the chief of clinical trials for this area of Health Canada that regulates biologics. We have a little bit extra scrutiny over our products, and we're defined by the products that we review, in that our products are just that much more complex. They're a grab bag of things, from vaccines right through to therapeutic proteins that are made from a kind of fermentation process in big vats and then hooked up, as you are well aware, with monoclonal antibodies to yttrium or to other things. And so we have to we have a different level of scrutiny on the quality of things. And so when it comes to opportunities, I discussed the approach of converting what have been considered new drugs to old drugs, to avoid clinical trials where that makes sense. The special access program, where we can sort of blend special access with clinical trials to make treatments available earlier. And as I say, Dr. McEwen has utilized that for MIBG to make it available, and hopefully that'll work with lutetium. And the one thing that we can't address is the challenge that remains with funding projects in the absence of a business model for products like the nuclear medical products that, patents are not available, and the rights then seem to bounce around from one corporate entity to another, and no one really comes through with the amount of support that's required to bring those. So in closing, I'd like to thank you for the opportunity to learn about CNETs firsthand, and let you know that I personally pledge to offer as much assistance as possible to aid in advances in this area. And again, I want to thank CNETs and my colleagues Agnes Klein and Celia Lorenko, who have tremendous expertise in this area.